I'd like to welcome you all to the Sedgwick and Sullivan Group webinar series. Today's topic explores risk identification and remediation tactics in ambulatory practice, and it is presented by Ann Gaffey and Dr. Dan Sullivan. Ann Gaffey is the Senior Vice President of Healthcare Risk Management and Patient Safety for the Professional Liability Division of Sedgwick. She is a 29-year career risk management, quality, and patient safety professional. She has extensive consultative experience working with hospitals, physician offices, and long-term care facilities in identifying areas of risk and developing risk reductions, patient safety, and mitigation strategies. She is the 2015 President-elect for ASHRM. She's the Vice Chair of NIC-MERP, a member of the Board of Directors for the National Perinatal Information Center, she's an advisory task force member, and a National Transitions of Care for the National Transitions Care Coalition. She's a frequent national speaker and author. Your second presenter today is Dr. Dan Sullivan. Dr. Sullivan is a board-certified emergency medicine physician for over 30 years. He earned a GAD in 1989. He is the former chairman of the Midwest Emergency Associates, LLC, a past president of the Illinois College of Emergency Physicians, the recipient of ACEP's Outstanding Speaker of the Year Award, a recipient of ACEP's Excellence in Health Policy Award. He founded the Sullivan Group in 1998 to leverage technology to efficiently deliver comprehensive solutions to improve patient safety, reduce medical errors, and reduce exposure to litigation. And now, without further ado, I'd like to hand things over to your first presenter, Ann Gaffey. Ann, the floor is yours.
Thank you and welcome, everyone. I'm really pleased to have the opportunity to present with Dr. Dan Sullivan today as we both speak about risk management and patient safety opportunities in ambulatory care. We both feel that the work we do is supportive of each other's expertise, and I'm happy to have a chance to collaborate with the Sullivan Group today. I'm going to start us out at the 25,000-foot level, examining the big picture of risk and safety in office practice and ambulatory care settings, with a focus on 10 areas for further evaluation that my team believes are critical indicators of risk and safety in an outpatient setting. From there, I'll hand it over to Dr. Sullivan to really take a dive into the clinical side of where things go wrong in diagnostic and other processes in these ambulatory settings. Hospitals increasingly are losing patients to medical care delivered in other settings. They're operating with fewer beds or closing outright. Hospital leaders are seeing patients with high deductible insurance policies seek care in lower cost settings to hold down medical bills, and that adds to our already growing demand for ambulatory care. And rather than spend money on new hospitals, the capital is going towards building ambulatory care facilities. You can see that this data here is reflecting the trend we all suspect: a slow decrease in the number of hospitals and the number of inpatient days. Intuitively, we know this shifts patient care visits to ambulatory and physician practice sites. Over the past 5 years, the desire to become clinically integrated has driven many health systems to acquire and insure physician groups and their office practices. While this strategy may prove to be beneficial in the long run, it also presents a series of new emerging risks and liabilities that are unfamiliar to many acute care facilities. These data here also support what we know, that our pool of active primary care physicians is not at a level we need to respond to the growing demands for care that we have. While we see a slight increase, this is still at a level that's leaving many health systems feeling that they need to employ as many primary care physicians as they can support, so in the near future, they're not caught short in managing the patient population that their health system is serving. Last year, 64% of job offers filled through one of the nation's leading physician placement firms involved hospital employment, compared with only 11% in 2004. As of a year ago, about 60% of family doctors and pediatricians, 50% of surgeons, and 25% of surgical subspecialists are employees rather than independent physicians, according to the American Medical Association. Also, as an example, the American College of Cardiology reports the percentage of cardiologists employed by hospitals rose to 35% in 2012, up from 11% just 5 years earlier. Hospitals have been offering physicians attractive employment deals with incomes often greater than what they've been receiving in private practice in the last several years, since they need to form networks to take advantage of incentives under the new Affordable Care Act. So when that employment path is offered, that usually means professional liability coverage comes with it. Now you have a new set of risks and potential liabilities to evaluate and manage. So look at these numbers. From 5 years ago, over 1 billion visits. So when you extrapolate this data to your organization, think about how many patients are touching your health system, interacting with your now employed and insured physicians every day. And if you have a big, busy primary care office, that could be almost 200 patients a day in any one location that you rarely have time to lay eyes on. Of course, the opportunities in front of you are the opportunities for patient engagement, better population health management, and more efficient use of healthcare resources. But that also means an opportunity for error, or worse, harm for a patient. Some of what we know translates well in assessing frequency and severity of ambulatory risk and safety issues. However, many processes are unique to the physician office and ambulatory setting and not something we're used to evaluating from a risk management perspective. Immersing yourself into the day-to-day operations provides a unique view of norms and processes. Think about the office that you've acquired that has 5 people in it who've worked together for 30 years, or alternatively, a really high-volume practice with frequent staff turnover and low morale, or an ambulatory care center that's got a lot of part-time staff who come and go, and it's difficult to ensure that everyone is maintaining the same level of confidence or competence around the procedures that are being carried out. Engaging staff and physicians allows them to share their barriers and challenges to achieving high levels of safety, but it also gives you a chance to see what they might be doing that's great, and a practice you can translate to other ambulatory settings in your health system. Next, I'm going to touch on what we consider to be in the top 10 of our critical risk and safety indicators when we go into an ambulatory care setting, and particularly physician offices. What we are doing while we're there is spending the day meeting staff, talking to them one-on-one, gaining an understanding of how they practice and interact with others in the office, speaking with physicians or not, some aren't always interested in speaking with us, looking at policies and procedures that are in place or not, going through exam rooms, opening doors and drawers, going through cabinets to see what's accessible to patients and visitors, seeing what medications are available, are they expired, are they secured, doing all kinds of digging around. What this is doing is giving us an opportunity to see how the practice has been running, what the culture in the office is, and really get an understanding about where there might be opportunities to improve patient safety and reduce risk. So let's dive into number 1, diagnostic testing. The diagnostic testing process can be fraught with opportunity for error and harm to a patient, particularly in the ambulatory side of the world, and most particularly in physician practices. So if you start with the most basic process of reconciling results with every order written, that's one area to begin your assessment. So ideally, what you're looking for is a process in place to identify what orders have been placed, track each of those orders all the way back through receipt into the office, look for a review and acknowledgement by the ordering physician. If the result didn't come back, make a determination as to why not. That might involve phone calls to the patient to see if they got the test, and if they didn't, ensuring that the physician knows that that test wasn't completed, and make sure that the physician can make a decision as to whether or not that has an impact on the diagnostic process that's in place. Look for that acknowledgement by the physician of the result, a completion of the reconciliation by notifying the patient, whether it's normal or abnormal, and closing that loop. One of the things that you'll find in the offices and the ambulatory settings that have hardwired this process is that engagement of the patient in the process really adds to the safety net. If your providers are saying to the patients before they leave, If you haven't heard from us with your results within the next 2 weeks, please make sure that you call the office. They sometimes can be that last catch to make sure that results have been seen by those who need to see it. Also, look at the process of labeling specimens. So, who's involved with doing what in the office? If they're drawing labs, does a medical assistant bring a draw kit, take the blood, then carry everything back to the lab area and label it there? That's not necessarily a safe practice, as we know, not labeling at the point of care. Are urine samples piling up in the box in the wall in the bathroom? So really understanding where that process that can really end up being a very high-risk process for a patient is taking place. Finally, evaluate your critical result reporting process. Evenings, nights, weekends. Most places have that down pretty well during the day. There's a good process in place. But if there's a reliance on calling physicians on call, if the call schedule has changed, does the answering service know who to call? And then how is that communication being documented? Let's take a look at medication safety. Now, some recent publications estimate that nearly 4.5 million ambulatory visits occur yearly due to adverse drug events, with older patients and patients who take more than 6 medications daily being at increased risk. While the study didn't assess the preventability of adverse drug events, prior studies have found that many patients suffer these ADEs in the outpatient setting, and they're often linked to high-risk medications. So when you think about and look at the medication reconciliation process, how is it done in the ambulatory setting, if at all? Who's actually carrying out that process? Is it a physician, a registered nurse, a medical assistant? What data is being collected, and are they doing it at every visit? Is it a process that's done on paper, or is there an electronic medical record that can be utilized? And if so, are they maximizing the functionality of every part of that medication field, if you will, in the electronic record? For example, if they're documenting allergies, are they using the functionality where they can document severity and reaction? Does the physician or the provider ordering medications have access to patient data when they're prescribing? Much harder to do in an office that's on paper records, depending on how well that office is organized and how they secure their records. That may be information that's not easily available when prescriptions are being written. Take a close look at the storage and inventory of medications, particularly sample medications if they're being supplied out of the office. Often you might find a closet that's unlocked and disorganized and could have many medications that are sitting, some sitting next to each other where it would be easy to pull the wrong drug or a drug with the wrong dose. Establish an inventory process and ensure that the office has a way to track lot numbers so that if there's a recall, they have the ability to actually contact the patient who received that sample medication and let them know about that recall. Are they dispensing with labels? Are the medications secure? And does that include securing prescription pads? When looking at who's actually prescribing, if there's a physician assistant or a nurse practitioner in the office, from a statewide perspective, you need to ensure that you understand what the prescriptive authority is for these mid-level providers in the state that they're practicing in. If there's medications that are stored in a refrigerator, perhaps vaccines, and these settings are in a commercial building, for example, what if the building loses power over the weekend and the medications that are stored in those refrigerators have gotten to a temperature where they're no longer effective? So looking at some of these, what we might say are nitpicky but important practices, can help to improve the safety around medication use in the ambulatory setting. Well, we know that current measles outbreak has received major news coverage in the U.S. because this highly contagious disease that we actually had almost eliminated in the United States in 2000 after decades of work has begun to spread again. And in January alone, the number of those cases in the U.S. climbed to over 100, which was almost twice of what we saw in 2012. Almost 650 cases last year. And then think about our recent scare with Ebola and all the other infectious diseases that a patient could come walking through any of these ambulatory setting doors with. So let's start by talking about management of those patients with infectious diseases. An office practice may or may not have that information before a patient walks in. But if they do, are they giving consideration to where physically in the office that patient could be seen Is there an exam room near a back entrance that could be used? And are they scheduling those patients at the end of the day so that only one terminal cleaning needs to be done and there's minimal exposure to the other patients presenting? Hand washing, probably one of the key elements of patient safety that we can espouse well into the future. Observe hand washing practices when you're in these settings. If the sinks aren't wet, they look like they've been dry for a long time, they may not be being used. If there are hand pumps with gel that have sticky blobs stuck in the end, they're probably not being used. But go back and think about the number of patients that are being seen in these office settings and ambulatory settings on a daily basis, possibly 200. A lot of patients for staff to be handling and physicians to be handling without good hand washing practices. From a specimen handling perspective, are they being handled appropriately and stored in biohazard containers? And are they bringing them out and putting them on the same counter where perhaps staff put their lunch or using a refrigerator in the office? One of the things that you learn as you start assessing risk and patient safety opportunities in these settings is that there is little standardization in practices as you go from office to office. So what might be a great office, on one floor, you can go into the next one and find that they really haven't changed their practices for 30 years. A big piece of safety to look at is the equipment processing and sterilization process, if the office is doing any kind of procedure. So are they using an autoclave? And if so, do they have the appropriate biologic indicators? Are they sending equipment out? Are they using single-use equipment? Are they maybe reprocessing single-use equipment? Is it cold sterilization? So really, bring in experts as you need to evaluate the infection prevention practices that are in place in some of these settings. Also look towards the CDC. They have some excellent materials for outpatient and ambulatory settings. And then just general office cleaning standards. As you talk to folks and learn what do they do in between patients, what are they doing at the end of the day to ensure that the surfaces are clean, and include asking them about keyboards, one thing that folks really don't think about often. We move on to communication and teamwork. We know that poor communication is high on the list of contributing factors in adverse events, and those events are often leading to malpractice claims. So ask the staff in the office, how accessible are patients during the day, or physicians during the day, for urgent issues that might arise? If they need to interrupt them in a room, are physicians receptive to that, or do they get annoyed? Are there any regular meetings with physicians and staff to discuss complex patients that the practice sees, or to review patient flow issues, or turnaround time, perhaps, for reviewing results that are compiled in the office? Are there ever any opportunities for the physicians to provide education for the staff, particularly in those specialty offices? Offices also vary quite a bit in how they communicate with the outside world. Do they have a company email, personal email? You might even find a range within one office where one provider could be communicating with patients from their personal email and everyone else is using the company email. In addition, we know texting is quite prevalent everywhere. We need to understand who is texting, about what, and then determine how they can implement HIPAA-compliant texting. We know it's not going to change. I think we need to acknowledge the workflow that has developed with the use of texting and guide solutions that will maintain appropriate patient privacy, as well as ensure that communications about patients are accurate, because we get into that problem where they're texting information trying to avoid PHI, but in theory what they could be doing is confusing the receiver about who they're talking about. Finally, determine if any formal teamwork principles are in play. Encourage morning briefs. It helps with the schedule flow. It can offer information about a patient coming in who may have been seen in the emergency department the night before, and things like that. If you spend a day in a physician practice, you will quickly learn about the teamwork within that office. If there are cliques, if task assistance is offered easily and often, and sometimes that takes an opportunity to sit down and have some pointed questioning one-on-one, but it will help you understand patient flow and how patient satisfaction may be impacted. As you would expect with clinical emergency management, different offices have different levels of preparedness for medical emergencies, and that's based on the type of practice that they are. And appropriately, the response for some is going to be to call 911. However, there are going to be some specialties where you want to see a higher level of preparedness to respond to a medical emergency. For example, a cardiology office that conducts stress tests or an office that conducts radiology exams with contrast. Those offices with a higher risk of a medical emergency should be appropriately prepared with the right medications, the right equipment, and appropriately trained staff. In addition, there should be a process to regularly check the medications for outdates, functionality of the equipment, for example, defibrillators, security of the medications, and competency of the staff when responding. These, if there's a medical emergency that arises, it should not be a surprise to staff about how to respond and who has what role in that situation. The entire response plan should be memorialized, including the supplies, how often they're going to inspect the supplies, and staff and physician competency requirements, particularly around BLS and ACLS. Practices that really achieve those high levels of safety conduct mock drills. Just like we have in the hospital setting, it's equally important in some of these busy offices that do have high-risk procedures going on. And when an event or 911 is called, there should be a debrief with everybody who is involved in that activity. Busy offices have many patients calling for a myriad of reasons, so you want to look at those telephone procedures and triage processes. There's emergent or urgent problems they're calling for, need for medication refills, requesting test results, reporting home monitor results. You definitely get the picture. And when you're evaluating any of these settings, evaluate the triage process to see who's involved, what protocols are available, if any, how problems are elevated, how these calls are documented, all the things that you would want to see around this process. You may find some offices using staff for this function who don't have the requisite education, training, or experience to perform this level of triage. There may be no physician-approved guidelines, and what that is doing, it could be placing these patients at risk if the person on the other end of the line is non-clinical or is overstepping his or her bounds. And also then determine where these phone calls are being documented and who has access to them. After hours, physicians have many phone calls with patients at night or on weekends, particularly in some internal and primary care practices. And what you want to do is ascertain, if at all, these calls are being documented anywhere. The information or the medical advice that's provided could be critical in the course of this patient's treatment, and if it's not memorialized somewhere, inappropriate care decisions could be made by the next person accessing the chart if this information is missing. And certainly I think most of us have seen in malpractice cases where this lack of documentation can be harmful to the case because critical information that might have been relayed in a middle-of-the-night call isn't memorialized. So a process to collect that information should be in place with the best-case scenario being contemporaneous documentation in an electronic medical record. Role confusion is commonly seen in outpatient settings, and I think we do that to ourselves because we often have staff wearing the same scrub suits. Often you don't see name tags on folks in ambulatory care, and particularly in physician practices, or they have name tags that don't clearly identify who they are and what their role is. Ideally, you're going to find some job descriptions to formalize every team member's role, including the scope of what they're allowed to do. For example, rooming a patient, drawing blood, giving injections. But what you might also find is that everybody in the office is referred to as a nurse, when in fact they might be a medical assistant or a lab technician. And it's important that patients can clearly identify the role of each person they interact with in that ambulatory setting. Is it an RN? Is it an NP, a PA, a medical assistant, a lab tech? I've had the experience of speaking with a nurse who just worked 3 or 4 days a week, and she stated that when she was off, the medical assistant did the things that she normally did because she was bright and they had trained her to do it. Well, that may not necessarily be within the scope of practice for that person who's an unlicensed personnel. If NPs and physician assistants are used as part of patient care delivery, you're also going to need to know your state-specific regulations around collaboration and supervision. And I think you all know that's really changing quite a bit over these last few years as we're recognizing the need for greater capacity in our system to care for patients. We're seeing broader arrangements. Some states, actually, nurse practitioners don't need any supervisory physician at this point. So you want to understand what those regulations are. Again, as I mentioned before, about prescriptive authority, number of providers a physician may supervise, things like that. For example, a new physician assistant in the office may have a limited scope of practice that extends over time. as the physician becomes more comfortable with them, as the physician's scope expands. If that's the case, then the supervisory agreement has to be updated accordingly. More and more procedures are being performed on an outpatient basis, including some surgeries that used to be performed in the hospital setting. I think we all know here there needs to be written policies and procedures that are going to guide those pre-procedure activities such as consent, what patient assessments are necessary, use of the universal protocol, setup of equipment and supplies, what's going to happen during the procedure, how it's documented, all those things that we're looking for around procedures and surgeries in the outpatient setting. Particularly evaluate the informed consent process in the office setting to ensure that the physician's review of risk, benefits, and alternatives is documented in the chart and that the patient has acknowledged the process and that they have not delegated this process to someone else in their office who's not a physician. And of course, if any type of anesthetic is used, that really needs further evaluation, just as to the level of anesthesia, who's administering it, evaluations, monitoring, and so on. One thing we probably didn't spend as much time on, if doing this 5 or 10 years ago, was really what's happening around violence prevention and control and the evaluation of workplace violence. We know that violence in healthcare settings is continuing to make the news. Unfortunately, we don't know when or who might initiate some very egregious behavior against any of our physicians or staff in one of these settings. So as you visit ambulatory centers and physician offices, pay close attention to the environment the space is in. Many of these facilities are located in a commercial building that has other non-healthcare businesses in it. So if, for example, there's a sleep lab that has patients coming into a commercial building after dark with one sleep lab tech alone in the suite, what security measures are in place for both the tech and for patients when they're alone in the suite at night in this large commercial building? If there are no alarms on the building, and you have a staff person coming early in the morning and alone, what's available for them to conduct a safe walkthrough of the suite? It's uncommon to find office practices that have conducted training on workplace violence, but excellent resources are available through both the Center for Disease Control and Homeland Security to respond to this educational need. And finally, health information management. Spend time when you first visit an outpatient location, first of all, just sitting in the waiting room. Observe staff practices when interacting with patients on the phone, see what you can hear. How are they treating patients and how much can you hear when they're checking in and checking out? When you're touring the exam rooms, determine if you can hear conversations from the next room or if PHI is left visible on a computer in the exam room when you walk in. Depending on the sophistication of the physician and the practice management leadership, there can be a wide range of compliance with the use of HIPAA privacy notices. In addition, depending on the medical record system in use, whether they're still on a paper record, a hybrid, or all electronic, that should be explored to determine if and how PHI could be accessed. For example, in a setting that has records, such as those shown on the right, large stacks in an unlocked room, this information could be widely available to any contracted people coming in after hours, such as housekeeping services. With copies of driver's licenses, insurance cards, and more, it's really like a jackpot for some of these folks, and the potential for a breach could be quite high. So to summarize, as you consider some of the information I've presented here, think through how you can engage your employed physicians and their staff and others in ambulatory centers in risk reduction activities to address some of the issues I've briefly raised and what my team considers to be critical risk and patient safety indicators. Very effective and efficient education can be provided using learning management systems that allow you to share important content to address some of these in a consistent manner to a large number of people at their convenience. And that's difficult to do when there's a small risk and patient safety department. So with that, I'm going to pause here and hand the presentation over to Dr. Dan Sullivan.
Well, thank you very much, and welcome to everyone who is attending. It's very impressive, the interest level for these issues in ambulatory care with the number of attendees. Very, very excited to be working in collaboration with Ann and with Sedgwick to do this presentation. And Ann, that was really great. And as you mentioned, I plan on starting at 20,000 feet and drilling down on key clinical drivers of adverse outcomes and litigation events. So we'll be looking at some data. But the Sullivan Group's mission is creating scalable solutions to reduce medical errors and improve patient safety. So although we're going to start with the data, we're going to drill down until we get to ways that we can solve issues related to patient safety and reducing litigation. So let's start here with the data. This is thanks to CRICO from their National Landscape document. As you can see, we've got 4 high frequency and severity. We've got surgery up there. We've got medication errors up there, emergency OB. But then we've got this failure to diagnose bucket. Now let's take another look at that. While surgery has the highest frequency of cases, diagnosis-related allegations account for the highest total incurred. So we're looking at one data source right now, and with it, we're focusing on this key issue of failure to diagnose. And if you're focused on the failure to diagnose, then where is that coming from? The majority of diagnosis-related cases are originating in the ambulatory setting, so that's key for us. And together, general medicine and emergency medicine account for 36% of the cases and 39% of the dollars associated with diagnostic allegations. So clearly, we need a focus on the failure to diagnose. And in getting ready for the presentation, I wanted to make sure that I could find every source of data to give us focus that was available. And so the CRICO data is tremendous. Here's a British Medical Journal Open article, recent, and they did a computerized systematic literature search. They found 7,000 articles, 34 studies, 15 from the USA, the UK, Australia, Canada, and 2 from France. And the overwhelming conclusion in the article is that the most common misadventure resulting in claims was the failure to diagnose or a delay in diagnosis. And the second most common misadventure resulting in claims was medication errors, 5.6 to 20% of the articles that were reviewed. Another great resource, PIAA, in their cumulative analysis, 2003 to 2012, and I'm sure many of you listening have seen these documents. The error in diagnosis, 58%, overwhelmingly #1 in both frequency and severity in family practice, internal medicine, primary care. Again, no surprise, with medication errors in second place, and improper performance at 13%. Of what? Of prescribing, of history taking, of physical examination. And again, we're way up here at 20,000 feet. We're recognizing a key driver is a failure to diagnose medication errors, and here PIAA is giving us some additional information on improper performance. And so we're going to drill down on that. And we firmly established it's the failure to diagnose and medication errors are our key drivers in ambulatory care. So the next issue, well, what are we failing to diagnose, and why are we failing to make these diagnoses? And I heard some of this in Ann's presentation, and so this is kind of hand in glove, that overview with some of the whys Ann has addressed, and I'm going to do it again. What are the at-risk medications? And it's one thing to say medication errors is a key driver. What are they? And why are we making these medication errors? Well, back to the BMJ Open article for just a moment. What are we missing? What are the diagnoses? You know, and I like, when I do these presentations, to invite you to be thinking as we get closer and closer and closer in this drill down, what could we be doing that would be a scalable system solution to make these problems go away? So from the BMJ Open, we've got cancer, number one, breast, colon, melanoma, lung, the circulatory system, the failure to diagnose myocardial infarction, and others that are mentioned as frequent in that article, appendicitis, ectopic pregnancy, and fractures. Okay, it's the failure to diagnose, and there's what we're failing to diagnose. And then let's take a look at some of the whys. Why are we failing to diagnose? Well, the failure to order a diagnostic test, maybe a screening colonoscopy, the failure to create a proper follow-up plan. Here's a repeat from another study, an inadequate history and physical examination. So surprising, isn't it? The basic elements of history taking and basic elements of the physical examination, not there, not done, not documented. What could we do to create a system solution to improve that situation? Incorrect interpretation of a diagnostic test. We've got some of the what we're missing, and we've got some of the more common why we're missing from BMJ. PIAA, errors in diagnosis. What? Symptoms involving the abdomen and pelvis, chest pain, malignant neoplasms, bronchus, lung, colon, and the rectal region. Myocardial infarction, the failure to diagnose myocardial infarction. A little bit older study from Annals of Internal Medicine, but still, I think, incredibly valuable lessons to be learned here. A retrospective review of 307 closed malpractice claims from 4 different insurance companies. 181 claims involved diagnostic errors that harmed patients. So let's add a little more to our profile. Well, what are we missing? The failure to diagnose cancer is number 1, 106 out of 181. Breast, colon, rectal, skin. So the data around this science is imperfect, but trying to get every resource available to try and get pointers to the key drivers. And here we've seen several very respected resources and very interesting articles, and the what we're missing is becoming pretty clear. Next most commonly misdiagnoses, infections, fractures, and myocardial infarction. You know, we've seen those before. And the what? So what we're missing, and what's the failure to diagnose? But here's some whys from the Annals of Internal Medicine. Failure to order an appropriate diagnostic test. Failure to create a proper follow-up plan. Failure to obtain an adequate history or perform an adequate physical examination. Every time someone takes a close look at the data, the whats and the whys are lining right up. Incorrect interpretation of diagnostic tests. Fascinating. Another key, another pearl from that article. Cognitive errors were involved in 96% of the cases. Mistakes in judgment, 87% of misdiagnoses. Lack of technical competence or knowledge, 58%. Lapses in vigilance or memory, 41%. When you go on shift and you haven't taken your ginkgo biloba, there's just no chance that you can know every drug in the brown paper bag. there's so much to know in the world of ambulatory care or urgent care medicine. Everything's walking in that door. You know, if it was just a low back and that's all I did for a living, I'm not sure that I'd have too many lapses in knowledge, vigilance, or memory. But in ambulatory care, with the laundry list of complaints that walk in that door, could it be expected that the team would know all that's necessary? You know, gee, that sounds like the human condition to me. So in any solution, any scalable solution, you simply have got to take this into consideration. All right, let's flip over for a moment. So that the other big driver was medication errors. And what medications? Which are the ones, and what happened exactly? There's steroid preparations, antibiotics, anticoagulants, antidepressants, and antipsychotics. And I could go on for the rest of this period, the rest of the presentation, talking about exactly how that happens, the many ways that there can be problems with those medications. So there's the what in medications and the why. Inappropriate medication, wrong drug, drug administration errors, dispensing errors, and adverse drug reactions. From PIAA, diabetes, disorders of lipid metabolism, obesity meds, heartburn meds, back disorder medications. Doesn't get as quite as specific as the British Medical Journal does, and I really appreciate that drill down. All right, so we know it's the failure to diagnose and it's medication errors, and now we know what we're failing to diagnose, and we've looked at some of the whys, and now we know some of the at-risk medications and conditions, and then we know some of the whys. So what? So what do we do about it? How do we get to the point where we can actually create a solution? Well, this is the general approach that the Sullivan Group has been taking for the incredibly 17 years that we've been alive and doing business. We recognize the human condition. We recognize that the team may not be aware of the what's and the whys. And so we deliver to the team that risk education. We do it through our learning management system. So that's absolutely key. If you're listening to this presentation 3 or 4 months from now, what will you remember from what we talked about? Maybe a couple of pearls. But we're talking about lives at risk here. So we believe that those key elements of risk safety and quality get delivered in online risk education in a scalable way. But so much can be done by delivering those same points to the bedside through an electronic medical record and electronic health record. And this isn't the whole laundry list of the tools that we might use, but the power of that is incredible. Let folks know what those issues are in risk education. Build those same risk safety and quality issues inside the tool that's being used in the ambulatory care setting. And risk assessment. I thought of about 20 things during Ann's presentation that need to be looked at, should be looked at in a regular way, a granular analysis of clinical behavior and the environment in the ambulatory setting. But you've got to give that data back to the team. And the power of giving that data to the team is phenomenal. I know I'm preaching to the choir here because this is what you'll do. You've identified a problem. When you give that data back, it's amazing. It's just amazing what can happen. We've done this now broadly through our comprehensive online risk education, and my background's emergency medicine. I just can't do it in OB prenatal. I can't do it in peds. I can't do it in psych. I just don't have those skills. And so we have been looking for 17 years for those people with that passion who can help us to craft those tools that we deliver that have been shown to really make a difference to actually reduce errors and improve patient safety and reduce litigation. So we looked at the whys. Remember, and 98% involved cognitive errors, vigilance, memory, knowledge base. And so deliver education specifically about cognitive errors in medicine. This fascinating discussion about the way the mind works, heuristics, method of error analysis, anchoring, and premature closure, medications, right? Number 2 driver, 11 simple strategies to prevent medication errors. Communication issues, discharges. One of the whys was inadequate instructions on discharge. Key moments in patient care at discharge. Communication strategies to improve patient safety in high-risk situations. And here's just one of over 100 courses on the failure to diagnose. One of our big drivers here was the failure to diagnose myocardial infarction. And so here's a course. There are actually several, specifically on that issue, the failure to diagnose, deliver that education. And then collect the data. What are the big issues from your ambulatory setting? What are they? And is it clinical? Is it environmental? It's, we frequently are asked by clients, listen, we need to measure that. We need to give the data back. So gather the data to drive meaningful clinical and environmental change. And you'll find something like this. The failure to diagnose myocardial infarction. Well, here's an analysis in a huge ambulatory setting from a number of doctors evaluating risk factors for acute coronary syndrome, aortic dissection, and pulmonary embolism. And look at that variability. That variability's got to go away. The only way you could do that is to educate and to give these people the data and then perhaps build it into the electronic health record. And here's an assessment, outpatient prenatal. And even though there's not a lot of red there, the red is really dangerous. There's a group B strep positive that didn't get treated there. And you just can't have that happening in your setting. Clinical pelvimetry, there's a good amount of red there. If you take a case to court, the plaintiff's going to be going after clinical pelvimetry. And finally, just a few looks at an electronic medical record, just a generic electronic medical record. And what you see here are, I'm in chest pain. Not having chest pain, I'm looking at a chest pain template. And these are key areas of history and physical exam. Remember the whys? History, timing of onset is critical in the chest pain patient. Associated symptoms, this movement of pain issue. What do? Make them red. Just make them red. And the red can go away. Get rid of the red. It's incredible the impact this has on the quality of documentation and what a driver of quality. And immediately available is clinical decision support. There's risk resources there. One of the things we don't do is adequately consider the differential diagnosis. Well, it's immediately available. And best practice on pulmonary embolism, dissection, and the failure to diagnose myocardial infarction. Well, okay, so this patient came in and has had an hour of pain, and I work in an ambulatory setting. I haven't had my ginkgo biloba, and I'm going to order a troponin. Well, when does troponin turn positive? I don't remember. I'm one of those humans from the why slide. Don't leave your user interface, cardiac marker timing. Troponin turns positive at 3. Why are we not diagnosing myocardial infarction? Well, maybe because the timing is off. 1 hour of pain, but we don't diagnose it until 3. How incredibly powerful is that? Or give them evidence-based medicine. Give me the evidence to be able to, in an evidence-based way, say that this person doesn't have a pulmonary embolism. Give me the logic, give me the calculators, let me write that note. So much more we could talk about in these tools and then the power of them, but I'll tell you, the combination of these things, recognize the drivers and drill down. We have to use data to drive system solutions. That data demonstrates that failure to diagnose and medication errors are the main drivers in ambulatory practice, adverse outcomes, and litigation. Our drill down demonstrates the specific causes, the what's and the whys of failure to diagnose and medication error. And that information must drive the implementation of system solutions to reduce risk, improve patient safety, and to save lives. And with that, I close. Thank you. And Jen, I'll turn it back over to you.
Ann and Dr. Sullivan, thank you so much for the wonderful presentations you just gave about ambulatory practice. I now